Good afternoon, everybody. Welcome to our webinar, Declaring Racism as a Public Health Crisis in Virginia. This is the fourth webinar of a series called Racism is a Public Health Crisis that will explore the background, context, and future of Virginia's recent resolution declaring racism a public health crisis. This webinar series is sponsored by the Institute for Public Health Innovation, Voices for Virginia's Children, the Virginia Public Health Association, and Virginia Tech Public Health, and the Department of Population Health Sciences and the Virginia Tech College of Veterinary Medicine. We will begin with the presentation with a diversity welcome. First, I'll begin. My name is Mike Royster. I'm Vice President of the Institute for Public Health Innovation, and excited to have you all as a part of the webinar series. I identify myself as a Black man, a father of 2 sons and 1 daughter, as well as a husband I consider myself to be an advocate for health equity and racial justice, and identify and incorporate that into the work that I do. I'll next invite my co-moderator and presenters to introduce themselves as well.
I'll go. I'm Kim Beskett. I identify as a white female, a mother, a wife, and an educator. And I have include also the equity inclusion into my classes.
Hi, I am Ruth Frierson, and I am a mother of 3 powerful and beautiful Black and brown Latina women, and a grandmother to an awesome, the best grandson there is. And I'm also an agent of change. I don't advocate for change. If I'm going to be involved, I'm going to bring about change. So I'm an agent of change in this equity space, but most importantly, I really want to be actionable in building belonging.
Hello, everyone. My name is Norm Oliver. I am the State Health Commissioner here in the Commonwealth of Virginia. I identify as an African-American male, husband, father, grandfather, 2 adult children and a 7-year-old granddaughter, and have been very active in fighting for health equity all of my adult life.
Good morning. My name is Stephanie Carrington. I identify as a Black female. I am a mother of 1 son and 3 daughters. I'm also the grandmother of 3. I identify myself as a community health worker, and I am also an advocate for health equity and racial disparity. And racial equity. I'm sorry.
Thank you, everyone. We appreciate your introduction, and I will turn it over to Kim to continue with the housekeeping.
Hello, everyone, and welcome. We're glad to have you on the webinar with us this afternoon. There are just a few housekeeping notes that I want to get across before we get started. Everyone will be muted throughout the presentation. If you do have questions for the speaker, please put them in the Q&A box, which can be found in the toolbar at the top or bottom of your screen. Some of our presenters are not able to join us for the entirety of the webinar, so there will be a time after their presentations where we will take questions and answer questions. Other questions will be addressed at the end of the webinar. We have some wonderful speakers lined up today. We'll start with Virginia State Health Commissioner and leader in advancing health equity in the state, Dr. Norman Oliver. Afterwards, we'll share a quick clip of Dr. Underwood, the Chief Officer of DEI at the Governor's Office. Abby Charles, Program Director at IPHI, will debrief on key takeaways from this video and how they apply to the community health workforce. From there, Stephanie Carrington, who is president of the Virginia Community Health Workers Association, and Ruth Frierson, founder of the company You Keep, will discuss the community health worker programs in Virginia. All right, I'd like to introduce Dr. Norman Oliver. Dr. Oliver is a state health commissioner at the Virginia Department of Health. Prior to this appointment, Dr. Oliver served as the Deputy Commissioner for Population Health for the Virginia Department of Health. For accepting the Deputy Commissioner position, Dr. Oliver was the Walter M. Seward Professor and Chair of the Department of Family Medicine at the University of Virginia School of Medicine. Dr. Oliver worked with others in the health department, other state agencies, and healthcare systems across the state to improve the health and well-being of all citizens of the Commonwealth. He is committed to a cross-agency and multi-sector approach. Dr. Oliver, we're great to have you here today, and we're looking forward to your presentation.
Thank you very much. So is it possible for me to share my screen now? Thank you. I'm really looking forward to the opportunity to present to you all today. I will spend a bunch of time talking about racism, race, and its relationship to public health. I think this is very important. I would say that it's very much the case that we live in a world that is really devastated right now with the COVID-19 pandemic, and also with a rash of racist attacks on people of color. We know particularly about police violence in the last several years against people of color, African Americans and Latinos in particular. We've seen increased attacks on people who are viewed as being of Asian descent. And these are things that have marked much of our society. In this same context, clinicians, public health practitioners, both are striving to do our best to care for patients, their families, and the public. As we take care of people in our clinic exam rooms and in the communities where public health practitioners are active, one of the things that's become increasingly clear to us is that the issues that we deal with in the clinic exam room or in the communities where we serve are conditions that really are spawned by the social and economic conditions in which people live, work, and play, the so-called social determinants of health. And we need to do something about those if we hope to really have any impact on the health of these populations. So how do we care for people in this unequal world in which we live, where we see all the social injustices around us that have such a great impact on these populations? I think the most important message that I want to get across to public health practitioners and to clinicians is that if the conditions in which people live, work, and play are the primary drivers of their health and well-being, then we have to get out of the exam room. We have to get out of the public health department offices and get into the world, join with others in changing the social and economic conditions that are responsible for the issues that we are trying to contend with. We have to join with others to create a world without racial hatred and without racial discrimination. It's not enough to do our more narrowly defined job as clinicians or public health practitioners, but we have to change the world in which we live. I think that begins with the understanding that race is a myth, but racism and racial discrimination are cruel realities. You know, throughout the history of biomedical science and other science, and throughout our social history, we have seen scientists and religious leaders, political leaders, and so on, are the ones who've been responsible for creating this myth of race. And I think this is really important for us to understand that there is one race, the human race, and that the differences between us are qualitative and small, not quantitatively large. It's ancestry and race that determines our genetic makeup, not skin color, hair color, eye color, or things of that sort. Those things are not markers of genetic differences. The slaveholders were the ones who created racism in order to justify their inhumanity in enslaving other human beings and forcing them into labor. Sometimes the racism that is out there that we have to confront is very explicit in our face. And very easy to spot. And most people actually, when you talk about racism, this is what they think about. They think that racism has to be explicit and very conscious in order for it to be an issue or a problem. But sometimes racism is unconscious. Here is from the Katrina hurricane and the aftermath of that in New Orleans. You'll see this top news clip: a young man walks through chest-deep water after looting a grocery store, so on and so forth. The bottom piece says 2 residents wade through chest-deep water after finding bread and soda from a local grocery store. The difference being, of course, that the person of color was a looter and the whites were just surviving by finding food. These sorts of unconscious things we see, or implicit things we see all the time in news reports and TV shows and movies and everyday sort of discourse. And that is something that very much upholds racism. Sometimes racism is internalized, and we see that as well. Some of you may have heard about the implicit association test, which is a psychometric test that measures unconscious or implicit bias. And you can take a racial bias test and with this IAT, and that's been administered to some 18 million people now around the world. It shows that for whites, the overwhelming majority of them have a implicit or unconscious pro-white bias, about 80%. But it also shows that about 40% of African Americans also have that pro-white bias, which is not surprising since we grow up in a society in which that dominant narrative exists, and it's of course impacts African Americans and as well as others. So I think racial bias is a very basic and root cause of discrimination, and we have to deal with it. But I also think that it's important to understand that racial discrimination is responsible for all kinds of problems. It obviously is an issue with respect to employment, our ability to find jobs. Once finding jobs, the differences in the amount paid are still there, with African Americans and other people of color making less for the same work as our people of European descent. Residential segregation marks every city in the United States. Here you see the distribution of the African American population in the U.S., which also I think can demonstrate to you how segregated the country is. Racial bias also leads to unequal treatment in medicine. A few years back, I participated in a study that looked at racial bias in pain assessment and treatment. And we found that among not only lay people, but among clinicians, nurses, medical students, residents, their false beliefs about biological differences between Blacks and whites was associated with their lack of a really adequate or objective assessment of pain in Blacks, and to their not providing adequate treatment for pain in Black patients. Health inequities, as you all know, really abound in the United States. Here we have some stats on just the differences here in differences in life expectancy, showing that there's huge differences versus whites versus Blacks. Disease disproportionately afflicts people of color. Among Black males here, you see we're looking at age-adjusted death rates in the United States a few years back. And you can see that for Black males and Black females, their death rates are much higher than for white males and white females. Disease, of course, also ravages the Black and Latinx communities. And you can look here and just in terms of diabetes and see that it is far more prevalent among Blacks and indigenous peoples and other people of color in the United States. Stroke is another disease that is devastating the Black community. And this chart here depicts how much more prevalent that is among African Americans. And of course, COVID-19 has shown once again that the hospitalization rates, the incidence, the morbidity from this disease was much more, it hit much harder the Black and Latino communities than it did the white communities. And it also shows again in the disproportionate death rates among African Americans. Cardiovascular disease is another one. And breast cancer, while it has a lower incidence among Blacks, has a much higher mortality rate among Blacks. And I already mentioned that COVID-19 is killing us and that we're dying at a younger age. The Virginia Department of Health has something we call the Health Opportunity Index. It's a compilation of a number of indices that look at things like housing, the affordability of housing, income, infant mortality rate, some economic measures, and so on. And we put those together and have found that when there is very low health opportunity index, we can find that that is associated with increased health risks. And opposite is true of some communities with high health opportunity index. Looking at this map where we've mapped out the HOI across the Commonwealth of Virginia, you can see that we have two Virginias. There's a rural south side of Virginia and a more urban north side. And the more rural areas have a much lower health opportunity index. We can map that as well at the city level, or actually we can map it right down to the census tract level. Those of you who are not from Richmond, if I told you this was a map of Richmond and we've mapped the health opportunity index, and you can see the areas that have very low health opportunity index. And if I asked you where the African American and where the Black and brown communities are in the city, you would be able to point right to them because they overlap those areas of low health opportunity. The other thing to note here on this graphic is we've mapped on top of this the life expectancy, with the larger red circles being longer life expectancy, and the smaller the circle, the lower the life expectancy. And you can see that those areas with low health opportunity are precisely the ones with the lowest life expectancy. The Center on Society and Health at the Virginia Commonwealth University here in Richmond took this same data, and they did I think a nicer cartoon of it. And you can see that in the north side of Richmond here, say in the Gilpin area, the life expectancy is 63. That's a decidedly African-American community, and just a few miles south across the river in Westover, the life expectancy is 20 years longer at 83. It's very important for us to recognize that these racial health equities are really the particular instance of the social inequities that exist in our society. And that's what we have to deal with. It's poverty that leads to ill health, and it's poverty that throws people into food insecurity. And it's poor people who are the ones who can't afford their medications. They can't afford transportation. This is a very interesting study that was done at National Transportation Service, looking at modes of transportation, and people at or below the poverty level spend an inordinate amount of time either walking or on a bicycle, taking taxis or public transportation, as opposed to their own means of transport. It's dilapidated substandard housing that spawns disease. And on top of living in those sorts of conditions, one of the things that is really very common among Black and Brown families is multi-generational homes. My own home is one. My wife and I live with our daughter and granddaughter in one household. This had a huge impact on things like COVID-19, for example, where many people, I believe, in those communities were exposed to disease in a way that did not happen else in other communities. So we're in multi-generational homes. We live in overcrowded dwellings, and the poor housing conditions are things that really contribute to disease. Asthma, for example, is a huge problem in the African-American and Latino communities, and many here in Richmond. The molds in some of the housing projects, like in that area of Gilpin, are quite high and really contribute to the incidence of asthma exacerbations and ED visits from those exacerbations. We also have poorer access to healthcare. It's been a historic problem that's been addressed and studied by people like Dr. Phillips and Dr. Pedersen, who did a really landmark study looking at access, which is both a condition of the shortage of primary care providers in general, but also the maldistribution of the providers that we have. So even though we don't have enough primary care providers, the ones that we have tend to be concentrated in more affluent areas within the urban centers. There's also a lack of adequate insurance coverage, which then leads to inability to acquire adequate health care. So we have these conditions, these health disparities that are ongoing, and then COVID-19 hit, and it just sort of brought to light once again these problems, but also it really, really just the amount of death, the amount of sickness, and just the trauma from the pandemic was very much felt in the Black and Brown communities here in Virginia and around the country. And as a result, then on top of that, you had the situation where there was the police violence against Blacks, and in particular the George Floyd murder. That was like throwing salt into the wounds. In the midst of the pandemic, while trying to deal with the devastation of COVID-19 on the Black community, you had this trauma that we all went through of watching this murder almost in real time. And people were fed up, and they struck out and protested and demanded justice for George Floyd. That cop killing was something that really, really was a turning point for what was going on in the US, and for that matter, around the world. Not only were there lots of demonstrations here with hundreds of thousands of people taking to the streets across the United States, but there were demonstrations all over the world, in Europe and Latin America, Asia, and other places. So if the health inequities that we see are really a particular instance of the social inequities that exist in the society, then in order to deal with these inequities, we must eliminate social inequity. And as I said before, I think it's important for us as public health practitioners and as people active in clinical medicine to get out into the streets and to recognize that racism is a public health crisis and do something about that racism, which again requires us to leave our exam rooms and our healthcare and health department offices. And by doing so, by joining with others, I just want to underscore again, the whole purpose of this is to create a world without racial hatred and discrimination. And without that racial hatred and discrimination, we'll have a world in which racial health inequities and ethnic health inequities can be eliminated. And I think that's it on my slides. So thank you. And I'll stop sharing my screen.
Right. Thank you, Dr. Oliver. We appreciate that very informative and inspiring presentation and to really summarize how racism affects health in Virginia and across the country. We do have a few minutes for Q&A. I know you will need to leave right around a little before 11:40, so we'll try to make sure we get you on the road by then. Let's see, there's a few questions that have come in both in the Q&A and in the chat. So I'll start with the Q&A. The first question that came in is, isn't continuing to use the term racism continuing the acceptance of race?
I make a distinction between racial categories and race. I don't think that, as I said, there's any biological basis to race, but racial categories exist, and racial discrimination based on those racial categories exists. So I'm one of those who would argue, for example, that we need to keep track of what happens to African Americans, what happens to Latinos, what happens to Asian Americans, even though those categories do not define any kind of biological differences. Those the racial discrimination or the social and economic exploitation of those populations does exist. And we need to be able to track it so that in our fight to eliminate it, we can have some way of measuring whether or not we're making progress. So I think as long as you are explicit about it in that way, then you don't wind up justifying or reifying the myth of race. So what I mean by that is if as a researcher, I publish a paper and I talk about, this happened to, here's the outcome among Blacks and here's the outcome among whites, and there's a difference, and I just leave it at that. The implication is that there's something inherent about Blacks and whites that are different. Whereas if I'm explicit about it being the result of racial discrimination or bias based on this racial category, then that doesn't buttress the race myth.
Thank you, Dr. Oliver, for clarifying that. Let's see, the next question, and there's kind of I think some that may be related. First, the person asking the question says, good morning, good to see people of color in decision-making positions. And they ask, what's being done to change the healthcare embedded racist system that has been around for a long time? And so maybe even as a part of that response, you can talk about things that Virginia Department of Health is doing in particular, as well as maybe answering more broadly if you so choose.
Okay, thank you. Very good question. I think that I'll talk about the Virginia Department of Health first. At the Virginia Department of Health, many of our programs are very focused on serving the most vulnerable populations in the Commonwealth. So programmatically, we're really doing a lot of work to try to improve the health and well-being of Black and Brown communities across the state. And so we're doing work around stroke or diabetes prevention. And within those programs, we really target and try to do a lot more in those communities precisely because they're hardest hit by those diseases. COVID-19 is actually a very good example. We knew going into the pandemic that the communities that were going to get hit the hardest would be Black and Brown communities and rural communities. And our health equity working group within our whole of government coalition around fighting the pandemic really helped us to have that health equity lens on every single thing that we did. So operationally, when we allocated vaccine to different areas around the state, or when we established mobile units or community vaccination centers and so on, we did it in ways that we could maximize our ability to reach those particularly vulnerable communities and bring them out. And we've been successful at that over the course of this pandemic. When we first started out in the initial days of the vaccination campaign, and back, when was that, December of 2020, the rate at which we were vaccinating Latinos, for example, versus whites was about less than half. It was about 30% of the whites. And now, and by the spring of this year, we had totally flipped that around, and we were vaccinating Latinos at more than the rate ratio is about 1.3 at that point. So, you know, it's like one would be equal to the rate that we were vaccinating whites, and we were doing much better in the Latinx community. That came from intentionally, very consciously targeting the most vulnerable populations. And we saw a similar increase in the African-American community as well. So that's on the programmatic side. On the organizational side, we have taken the approach that we want to ensure that our agency is one that is diverse, that is equitable in the treatment of employees, and that is inclusive, so that all people within the agency feel like they have and actually do have a seat at the table, and have some genuine agency within the agency, so to speak. You'll hear with the One Virginia plan that all state agencies are required to do this now, but even before the One Virginia plan, VDH was mapping out a diversity, equity, and inclusion plan for our agency. We have hired a chief diversity, equity, and inclusion officer to help oversee this work. It's not just about educating people on DEI and about racism and so on. But it's also about hardwiring this into our agency. So one of the things we're doing is we're taking a look at all of our policies, all of our procedures, all of our organizational practices, the way we do things around here, and taking a critical eye towards this, look at them and saying, does this policy, does this procedure advance diversity? Does it advance equity? Does it advance inclusion? And if it doesn't, how can we change it so that it does, so that we then become an organization that lives and breathes DEI? I think that's what needs to be done, not only at state agencies, but in institutes of higher education, in businesses, in our schools, all the institutions in which we live, because they are all rife with discrimination of all sorts, not just racial discrimination, right? But it's structural, it's built into those institutions, and we have a responsibility to unpack that and change that.
Thank you, Dr. Oliver. I see we're right at maybe a time for concluding your segment.
If there's one more question,
One
I'll
more?
take another. Yeah.
Sure. Yeah, we can look at one more. What accountability processes exist for doctors and other healthcare providers who display racist behavior with their patients? What can their coworkers or patients do if their symptoms are ignored, their concerns minimized, treatment denied?
So that's a nice connection to what I was just talking about, because if healthcare systems took that sort of view towards their policies and procedures, one of the things that they ought to do then is to have no tolerance for such behavior, and people ought to be disciplined for that kind of behavior. If it's in some cases, it's education about that behavior and how that behavior is problematic. In other cases, it may require more harsh disciplinary action. I think this varies from institution to institution. Unfortunately, in every healthcare system I've ever worked in, I would say that it would take a pretty egregious kind of racial or ethnic discriminatory act to result in disciplinary action. And those sorts of things do get acted upon. People can complain to an ombudsman or some other patient complaint kind of area and might result in something being done. But again, it's only the grossest sort of actions. My experience is that the day-to-day microaggressions against people of color or LGBTQ community or others, that stuff goes on without it being called out at all. And it's one of the reasons why I think these institutions need to take a hard look at themselves in order to change that.
Great. Thank you, Dr. Oliver. We appreciate your time and your presentation, staying with us a little longer than we had originally planned. And again, want to thank you, obviously, for the work that you and the health department have been doing for the past year and a half to really help us move through the pandemic, and the important work you're doing internally that you described in terms of your long-term efforts to really promote equity, racial equity, and other forms of equity and health outcomes as well. So again, thank you for your time and appreciate your participation today with us.
Well, thank you. IPHI has been a real strong partner of ours, as has actually every organization that's represented on this panel. It takes a village to deal with things like COVID-19, and we greatly appreciate the support and effort of everyone on this panel and the communities that you represent. We wouldn't have been able to be as successful as we've been if it wasn't for people like you and many of you on the actual front line of fighting this pandemic. So thank you.
Thank you, Dr. Oliver.
Thank you.
So now as we transition to the next aspect of the webinar, again, thanking Dr. Oliver for his work, we want to talk more about the One Virginia plan, which he referenced in his discussion. We did invite Dr. Underwood, who unfortunately did have a conflict and was not able to join us, but they did send a video that we would like to share to give an insight into the One Virginia plan created by Dr. Underwood under the guidance of Governor Northam. And so with that, I think we will begin the presentation or the video.
I'd like to talk about how to change long-held structural inequity. As was mentioned in The Color of Law. If you haven't read that book, I highly recommend it. But changing long-held structural inequity or racism must include intentional strategic planning and policy and legislative and programmatic interventions. As was mentioned in 2019, Governor Northam created the Office of Diversity, Equity, and Inclusion as one structural mechanism to collaborate with him and the entire cabinet across all the cabinet secretaries and agency leaders, all 140 General Assembly members, community stakeholders such as many of you on the call today, and public and private organizations in pursuit of making the Commonwealth a more inclusive and welcoming state where any business or person would want to come to live, learn, work, play, visit, or thrive. I want everyone to know who's listening out there today, this new office was codified in 2020 in the Code of Virginia with House Bill 394, which signals that I have a statutory obligation to share these best practices with you. What's more, I have a statutory obligation to partner with you and all state agencies and higher education institutions to develop a sustainable framework to promote inclusive practices, implement a measurable strategic plan to address systemic inequities, and facilitate methods to turn your feedback and suggestions, many of which we'll hear from today, into concrete equity policy. So I'd like to underscore something Governor Northam said. The administration is here to listen and to get suggestions. So please do continue to have equitable conversations. Next slide. So let's get back to your organizations. Who are you and who are the organizations that you serve? Let's start with a bit of a personal assessment for each of you. Implementing diversity, equity, and inclusion initiatives, or DEI, in any organization starts with transparent reflection and assessment. And as a teacher, everyone knows the test is sometimes hard. We hate tests, I know. But before any organization can start their diversity strategic planning or implementing diversity initiatives, such as hiring a diversity officer, which I know is the hot button right now. Everybody wants to hire a diversity officer. But I just caution you, before you do that, assess your systems, policies, traditions, and practices to learn what to do and what not to do. So let's take a look at this slide. Most organizations, both public and private, align with what we call compliance, or simply adhering to the EEOC statutes and expectations. This over-exemplification of doing just the bare minimum to stay out of legal trouble is true for most institutions of higher ed, state agencies, and really all organizations, public, private, corporate, represented by those of you tuning in with us this morning, and really nationally. There's been a true over-exemplification for EEOC compliance. However, as Dr. McDonald mentioned earlier, the goal must really be inclusive excellence, where organizations leverage and optimize individual differences as a source of strength and institutional effectiveness. At this level, there is a clear affirmation and respect for operationalizing DE&I, or inclusive excellence, in a strategic plan. So let's talk a little bit more about the One Virginia Plan. Next slide. The 5 goals of the One Virginia Plan for Inclusive Excellence is truly based on 3 monographs disseminated by the Association of American Colleges and Universities. I gratefully acknowledge the work of these scholars as an association that has really provided national leadership in the conceptualization and dissemination of this One Virginia Plan work. I do want to share with you the One Virginia mission is very much connected to the One Virginia Plan. And it really is to increase organizational effectiveness and for the state, the Commonwealth of Virginia, to become an employer of choice by doing more than just decreasing diversity at all levels of leadership, but really fostering inclusive excellence and a welcoming organizational culture that's really exemplified by a sense of belonging, generating knowledge about diversity-led innovation. And what I mean by that is linking our business goals to DE&I, establishing a shared accountability for visible equity, and fostering genuine community engagement. And this One Virginia mission is really about moving away from checking boxes and really rolling up sleeves and getting to work. Next slide. Now, I'm going to talk a little bit about the 5 goals of the One Virginia Plan. And I'd like for you to really dig in deep with me. This is the time for us to roll up our sleeves and think about how to apply these goals to your organization, whether you're a public or private organization, whether you're a college or university, or a nonprofit. The 5 goals of the One Virginia Plan for Inclusive Excellence is truly a way to operationalize and optimize diversity-led innovation. This plan was developed in collaboration with the Virginia Department of Human Resource Management, who served on an interdisciplinary volunteer executive steering team that intentionally sought public input from stakeholders all around the state. And together, the steering team created an online toolkit for use by state agencies and any public stakeholder around our state in pursuit of collectively measuring these 5 broad goals that advance inclusive excellence. Now, I want to just share that the online toolkit will go live later this month and will be accessible by anyone on this call and really anyone around the country who would love to know.
Right. So hopefully everyone found that segment from Dr. Underwood's presentation to be informative. Now we have Abby Charles, Program Director with IPHI, joining us to provide us with a little more insight into the One Virginia Plan. She, in her role as Program Director, she oversees a network of community health workers and a portfolio of programs that provide training and technical assistance on different components of operationalizing health equity. Abby, welcome to the webinar.
Thanks, Mike. And thank you all. I think the webinar so far has been really enlightening. And I really appreciated the ground context that Dr. Oliver laid. And as we think about this One Virginia plan and the strategies that are being implemented, and what we saw in that video from the governor's office, really and truly, the vision is to develop Virginia into an inclusive state where all people could live, learn, work, play, and thrive. And in so doing, we really need a high-performing workforce that leverages diversity as a strength and strives for visible equity to empower all employees in Virginia to deliver public service with inclusive excellence and cultural affirmation, right? So as part of what that One Virginia plan really outlined were those key mission and goals aimed at achieving inclusive excellence at all agencies. And they talked about the fact that while this plan was designed for Virginia government, it is meant to be flexible so that we could all think about how do we integrate this into all organizations across Virginia. And Dr. Underwood really talked about that continuum of inclusive excellence, which includes the 5 dimensions listed on this next slide. And each of these dimensions could really be adapted to interpreted to fit your organization, right? So thinking about how do you ensure that you are facilitating access and success for all individuals, but especially for people who have traditionally faced inequities in your organization. So there is a complete toolkit on the Office of Diversity, Equity, and Inclusion's website, which will be distributed after this meeting. But a key piece, and one of those things came up in one of the questions that was asked related to, how do you hold doctors accountable who are engaging in potentially racist practices with their clients? And, oftentimes we don't see very overt racism. Many times it's microaggressions, it's subconscious and implicit actions that we're taking that we don't even recognize. So a key part of that process to changing culture will be different for each organization, but it will need to include transforming your climate and environment and how groups relate to each other, ensuring that there's education and training for all staff, right? Ensuring that there's constant, not just one training, that there's consistent training on understanding and assessing your biases and how that shows up in the work, and making sure that your systems facilitate for that ongoing learning. And ensuring that you have the infrastructure and accountability to support this inclusive excellence will be critical as well. And lastly, ensuring that you're engaging the communities that are most affected in your processes to ensure success will be a critical part. We often talk about diversity, equity, and inclusion and racial equity from an external lens. But I think this One Virginia plan really helps us to think about what do we need to do internally as organizations to ensure that the work we're doing externally is consistent with our values and the work that we're doing. So one of the pieces that we think as an organization, IPHI, we truly value the role of community health workers in changing our culture. And we believe that community health workers change culture internally, right? Because by integrating workers who are from the community, who sometimes share the lived experience of the persons we are trying to support the most in our communities, we will truly be integrating the voice and engaging the community in our own organizational policies and systems, and as well, creating systems by which we are increasing access and success of our community to improve public health. So we're going to change the slant of the talk next to really talk about the role of community health workers. And community health workers, they bring a unique perspective to public health, of course, which can help us get to the root causes of these health inequities. So as we are planning and designing our initiatives, integrating our staff, our community health worker staff, and helping us shape and understand what are the needs in our communities. What are you seeing on the ground? how do we ensure that we as an organization build our systems to meet those needs? And how do we ensure that we measure and use quality improvement strategies that integrate those CHWs as well to measure whether we're actually having an impact on equity in our communities? We often focus and emphasize on what community health workers can do for their communities and the impacts they can have on individuals. But in reality, while that's incredibly important, we shouldn't overlook the opportunities for bi-directional information flow from community health workers to the organizations that they are working with. Their deep understanding of community, their deep understanding of racial inequities presents a unique opportunity for us to achieve that inclusive excellence. So diversifying your workforce, at times bringing non-traditionally but critically important expertise to strategic and programmatic assessments and planning will be a critical role of community health workers. They're serving as those liaisons at times representatives of their communities. And their perspectives can help transform how an organization grows to achieve organizational excellence. They also serve as that direct link to the community and are so well positioned to improve an organization's community engagement. So in reality, because we have struggled as a country in really getting to the root causes of health inequities, while CHWs aren't the only solution, we've heard of in this webinar many strategies that we should be implementing. We do believe that community health workers are a key to eliminating racial and other health inequities. And with that, we are excited for our next speakers to talk more about the work that's being done across our state to formalize this public health workforce.
Thank you, Abby, for sharing your insight on the One Virginia plan. That was very informative and just so crucial for all organizations to implement the plan and ensure that there's racial justice and equity across all organizations. And also for introducing our community health workers and just how vital they are in that piece and everything else that they do. So I'd like to introduce Shanteny Carrington. Shanteny is interim president for the Virginia Community Health Workers Association. She is a founding member and helped with the development of the Virginia Community Health Workers Association. She's a certified community health worker for Richmond City Health District. She holds a degree in social science and education and is an alumna of the Grace E. Harris Leadership Institute. She also serves as a board member of the Market at 25th and the Creighton Redevelopment Advisory Board. Welcome, Shanteny.
Good morning. My name is Shanteny Jackson. I am going to sit in instead of Stephanie. There was some unprecedented situation, so I'm honored to be able to share some insight in terms of community health workers. How are they able to support strategies to combat racism, which is a public health crisis in Virginia and a high level of concern in our society. I would like to start by framing community health worker roles. Community health workers are frontline workers and members of community. That means that we live in community, we serve in community, we play in community, we actually are part of community. Therefore, our dedication is focused or has a priority to addressing needs at community level. We consider leaders and representation and an image of our communities. Therefore, there is a concept of identity that is essential in reducing racism in our society in Virginia. A few practical ways in which community health workers are fighting or combating racism at community level is that we do focus on 5 specific areas, and that is outreach, education, advocacy, navigation, and lastly, relatability. I'm going to speak about each one of those components or categories for us to be able to have a better picture, image of how simple it could be if we think about racism from a microscopic perspective. Outreach is necessary in all communities so that communities know where to go to. We want to reach them where they are. We don't have to set a parameter outside of the community. More so, let's come to the community so that they are able to have access. Access equals to equity and diversity. There are many of components of cultural connection in community that will make the outreach effective to those who we're serving. Education. It's extremely important to educate our communities about the challenges that they are experiencing and that we can learn from in order to do the next item, which will be advocate. We need to advocate for our communities. We are able, because of our qualities, to address the concerns that community members are reflecting or are communicating. We are ears in the community. We are eyes in the community. We are our mouth, our feet. We go where the information is being filtered. We also help navigate in order for access, in order for barriers or bridges to be broken or destroyed. We need to be able to navigate, to understand what is needed to address that system barrier that would restrain or restrict this individual from gaining access to resources, information. And lastly, relatability. Every community has a culture. Every population has a culture or a norm. We must understand that community health workers are derived or derivatives of that culture, of that norm, of that community. Therefore, are very much in a position of reflecting and understanding, empathizing, and being able to speak about these concerns and be able to express, advocate, and communicate how these issues affect communities. Racism, as we said it earlier, is a public health crisis, and community health workers can make a difference along with partnerships, strong partnerships, and collaboration and funding that can make these efforts a success. Thank you very much for your time and your attention. And community health workers do serve in community, and we make a difference in community. Thank you.
Thank you, Shanteny, for filling in for Stephanie. And for those who may not know Shanteny as well, she is the previous president of the Virginia Community Health Worker Association, who has played an integral role in moving the association forward over the last several years. We will have some opportunity for Q&A at the end. And so right now we will move forward to our other speaker, Ruth Frierson, who I have the pleasure to introduce. Ruth is a lifelong agent of change. Although the titles over her career might have changed, her commitment to be a catalyst for meaningful transformation does not change. She was part of the Study Resolution Committee with the Virginia Center for Health Outreach at James Madison University that studied the status, impact, and utilization of community health workers. As one of 6 CHW regional coordinators, she was a liaison and an advocate. Currently, she is the founder and CEO of The Company You Keep, a social enterprise focused on building belonging through meaningful systemic transformation. Ruth, we're excited to have you. Welcome.
Thank you for having me. So we'll get right into it. So my focus is this: to empower leaders, transform systems, and elevate people. And throughout that process, there are some pain points. So let's get started on our journey. So as Mike mentioned, I had the privilege of being a part of this study in 2004 and 2005, and in 2006, we submitted a report to the governor and the General Assembly with 7 recommendations, which we'll briefly touch on in the next slide. However, one of the opportunities that we identified was how we could maximize the role of the community health worker to address disparities, and so that there could be some changes in the community in reducing barriers, so that we can increase exactly what you've heard of, this morning, increasing access to healthcare and really being proponents of change, since they are in the community, of the community, and for the community. Go on to the next slide, please. And so here are 7 of the recommendations that we submitted then in how we identified supporting community health workers. The truth is that those recommendations still stand today, and we have not enhanced or moved much from the recommendations that we made in 2006. And that was to teach our community health workers, right, to really find some KSAs, identify KSAs for community health workers. Again, I want you to focus on the fact that this is how we identified supporting community health workers. To teach community health workers, to provide them training, to track their work, to integrate them in the community, to ensure that we provided funding for them and for their work, to report on their progress, and to evaluate, how they were doing. And, this is how we again identified supporting our community health workers was by enhancing their skills and their knowledge, skills, and abilities as it relates to the programs that they were implementing. The next slide, please. Here's where I believe that we missed the mark in 2006 and have the opportunity to improve things for community health workers, the communities, and the leaders that are trying to make changes into changes in policy. And one of them is for us to reflect on how do we empower community health workers to look at and report on structures that are not working, or systems that do not work to address the barriers that communities face and that result in inequities. So how do we empower community health workers? What are the systems and the structures that we're putting in place to ensure that they can be successful in the arduous work that they have? So if we are to add and maximize the role of the community health worker to be an advocate for addressing disparities and obtaining equity, then what are the structures that we will provide for them in addition to supporting their KSAs? What are the structures that we will provide so that they can be successful in addressing inequities? The other thing is, how do we provide systems where community health workers can report any failures on any of the practices that do not seem to be working? So we've been going at inequities, disparities, for many years since the civil rights movement. And we all heard this morning, from Dr. Oliver about the consistent disparities. And so these are systems that we need to be able to listen to community workers that can share the information about things that are not working. And sometimes those cause pain points. And thirdly, how do we ensure that community health workers are valued for their work, not just, for the relationships that they have, that we leverage the relationships of community health workers in the community and their influence and their knowledge. But how do we in turn value our community health workers so that they can be heard, feel empowered to make change? And these changes are going to come in as a systemic focus. So as a community health worker myself, since 2000, one of the biggest challenges was reporting failures within systems, because we're very program focused and behavior focused. We seek to change outcomes by changing behaviors, but we're still working within the same structure. So are there opportunities for us to enhance and to better support and empower our community health workers if they're going to be the most important partner with us in addressing inequities going forward? Next slide, please. And so I will ask all of us, do we have the courage to be curious and stay curious when things get hard? Can we evaluate systems and structures as well as evaluating the progress that community health workers are making? Can we support our community health workers by ensuring that we're learning from them and transforming the systems that need to be changed based on the things that they're reporting back to us? Are we curious enough to question the power that exists within these structures and the practices that are implemented that have not shown to produce any positive outcomes for communities of color and people and families of color? And so we've been practicing the same things for many years. We have talked about equal opportunity employment for many years. We have talked about health disparities for many years. We have had the data for many years on disparities. We know that, racism exists, and we've known that since the beginning of America. And so what we haven't done is self-evaluate it, right? Our positions of power and how we practice and use our power. And so again, it's just a self-reflection. Can we remain curious to really support, like we talked about back in 2006, to really support our community health workers to be the catalyst for change that is required? And so can we, again, revolutionize our institutional climates, as we were just talking about, the climate, the culture that allows these disparities to continue to be practiced within, within our systems? And how about we ask the question, we always talk about leveraging funding, which means many times, let's get the community health workers to do more with the same amount of pay, right? But what if we look at what is the meaningful return on investment for people who are investing, right? For people who have the power and the resources. So what if we asked those people that develop policies and have the power and the resources to report back on what we're getting for all the investments that we're doing, right? So we should not only ask more of the community health worker and without, and not talk about how we will invest in them and how we will hold systems of power accountable for ensuring that all the investments are providing some meaningful return, not only for the funder, but also for the communities that we're trying to impact. And all of this really does require innovation. Next slide. And so are we prepared to be a bridge over troubled waters? Again, these inequities have existed for many years, and there is no possible transformation without some pain points. So our community health workers have been really powerful and meaningful liaisons between organizations and community. And so I think it's time for us to ask ourselves, are we prepared to be a bridge and a liaison from resources, policies, and practices to our community health workers as well? For as much as we ask of them, can we ask more of ourselves? Next slide. And with that, I just want to highlight that tomorrow is Latina Equal Pay Day. And on average, Latinas are paid 57 cents for every dollar that is paid to a white man. And so I ask you to participate tomorrow, either on the summit or just through your social media feeds, through the hashtags that you see there. And so I thank you so much for allowing me to participate and to continue to have these meaningful conversations.
Thank you, Ruth, for those great insights. Very much appreciate your presentation. Now we will turn to the Q&A portion of with the remaining time of the webinar. And I do want to mention that one of our moderators, Kim Basquette, did have to drop off. So we do thank her for the time that she was able to join us. And so we will begin the question and answer with a few existing questions. Both and I remind everyone that you can insert your questions into the Q&A dialog box within Zoom. What we have so far is related to community health workers. How do you address boundary concerns with community health workers and presumably other professionals that may be a part of a team? Would any of our panelists like to respond to that question?
I can attempt to respond. I'm going to assume that they are talking about boundaries between, are they talking about boundaries? Can you clarify, like boundaries between community health workers and systems or families?
That's a good question. Maybe the person who looks like Johnny Cobb, families, he says, boundaries with families. Thank you, Johnny.
I think first acknowledging that it is a very fine line as a community health worker. That was a challenging piece to ensure that, you know, I was respecting boundaries. But I think it's a helpful reminder about how systems can be helpful to community health workers in that manner as well, to ensure that we're holding community health workers accountable for the work that they're doing and for the work that they're reporting on. Again, I think, I don't think it's exclusive to community health workers. I think it's just the field that we're in, that because we do really good work that feels really good, we tend to, you know, have the tendency to cross boundaries. And I think separating the good work that we do from the accountability piece of empowering families, I think will be helpful if, you know, managers of these programs also exemplify, you know, what boundaries are and what the expectations are. So again, I think it all comes from empowerment and being a good example as well.
I would like to add to the conversation is that in terms of our work, we usually are building relationship based on trust. Therefore, there are implied norms that we have either established with the relationship or we have expressed within the standards of our work. Pretty frequent example relates to gifts, and I'm a Latina, an Afro-Latina, therefore I identify with the culture of Latinos and other populations, but that's the scope of work that I pretty much have greater expertise. And so many cultural norms are that you give gifts, right, to those who have given you some service or anything of those lines. And so it is my and our understanding as community health workers that this is part of the work that we do, our scope, and therefore no acceptance of gifts are necessary or should be expected. And so we use work policies to support our decision and our expectations and the relationship. So in practical ways, this would sound like, thank you, Ms. Carmen. Today, we were able to help you with XYZ. Miss Carmen say, hey, I brought you a piece of cake because I'm so thankful for your work and all that you've done for my family. And I would say, well, Miss Carmen, that is very honorable from you. I really, really appreciate this, but unfortunately, due to company policies, we are unable to accept it. We are extremely thankful for your gesture. I would say share with your family, with a friend or someone who can also enjoy it. But here at the office, unfortunately, we are not able to do so. So that's just one example in terms of boundary and family connection. There's also that other scope in which we have boundaries in terms of scope of work. We cannot cross boundaries when we are working in a interdisciplinary team, which that's how we operate at Richmond City Health District. We understand that we cannot take the role of a nurse. We cannot take the role of a physician or clinician or anything or any other expert in any other content area. Whether it's counseling or whatever that may be. But we do partner with those organizations to provide the services. That's why I mentioned earlier that in order for us to work effectively, we have to depend on partnerships and therefore understand where the scope of work divides and how we can pass along and transition the client into the level of the service that they need. Again, having that understanding, having that relationship, having that trust, those are three key components for us as community health workers to build communities and reduce the incidence of racism and improve advocacy on behalf of our communities. Hopefully that helps.
Thank you, Shanteny. And I see our Abby, our other panelist, has her hand up. Abby, did you have something to add?
Sure, I can be really quick. I think oftentimes that tends to be a concern that we hear from a lot of organizations about the need to address boundaries. We have not, in the 10 years that we have employed community health workers, experienced any challenges with community health workers over crossing boundaries when it comes to families or community members. And I think what Shanteny just shared related to ensuring that, one, you have the policies in place that support community health workers to ensure that they know what those limitations in their role are, but also ensuring that through the training that you provide for community health workers, you are making sure that they are clear on the role, how to decide whether, if you're working in community, if this is your friend or your family member, that will not be someone who you work with as a client. So establishing those policies from training, as well as ensuring you have those policies in place, should be more than enough to ensure that that's not a concern in the work.
Thank you, Abby, as well as Shanteny and Ruth for responding to that question. Another question that we had in the Q&A is regarding, it was from Susan Sherman, who points out that she runs a free clinic in Virginia, and with limited resources, they're weighing the cost benefits of establishing satellite clinics in neighborhoods with low health outcomes versus investing in community health workers who work neighbor by neighbor to establish trust and to connect neighbors to appropriate primary care homes that already exist. And she says, knowing the problem is probably due both, do you have an opinion on which would be the better investment of resources, either establishing satellite clinics or investing in community health workers? Would any of our panelists like to respond to that? It looks, Rebecca, would you like to respond?
No, you can go ahead, Mike.
Okay. I guess my thought would be, I don't know, again, I don't know that it's an either or. I believe that community health workers play a critical role, and then assuring that you are engaging community health workers and then linking them to services that are available in the community. One of the things you want to avoid is having that outreach and not having the services that are available. So I think it does require some analysis to determine, what is really the cost. And then also recognizing that there's a lot of studies that are showing that community health workers, save money for health systems and have a very positive return on investment. And so I would wonder if that's being considered in the calculations around costs of either establishing clinics or hiring community health workers. So that's my initial thought, but I see that Abby has her hand up as well. So Abby, what would you add to that?
Yeah, no, I think, Mike, that would be a great approach. Of course, the both and is the ideal. In addition, thinking through, if you do, let's say, start with community health workers and create increased access or increased need for services, what systems are in place to facilitate easy utilization of what you presently have in place? So are there easy ways to provide free transportation or low-cost transportation to your services in the absence of having, let's say, that satellite clinic built out at the same time as the community health worker initiative? Is there an opportunity that with the community health workers, can you roll out a mobile program or something that's on an RV that is increasing that access and facilitating that connection? So thinking through, once you build that access through information with that community health worker, people might want to utilize the systems. How will you ensure that they have a smooth access to those systems if you do phase in those clinics? So just some considerations to think about.
Thank you, Abby. That's a great idea to have a way to kind of connect both ideas together. We do have, let's see, time for maybe one additional question. And this was directed to Ruth. I'm also thinking that maybe some of our other panelists may want to respond as well. Do you have suggestions on systems that organizations can implement for community health workers to report on systematic environmental, policy, and institutional issues as compared to individual or behavioral issues that you mentioned in your presentation?
Yes, so just so everyone knows, I submitted the answer on the chat. But what we did was we developed a data system as well for tracking institutional practices, policies, or any issues that arose as a result of structures, policies, or practices. And so we weren't looking only at behaviors and reporting that, but we created this reporting system called the barrier busting reporting system, where we started to track all the issues, policies, practices, organizational cultures that were creating barriers for families and community health workers. And again, and what we found is that we were able to really focus on addressing common barriers, because we found was that across regions, cities, and organizations, there were some some common barriers that came to the forefront. And so then we were able to strategically address those. So I'll just give you one quick example that was, again, just pretty easy. Again, our community health worker was able to identify this barrier, which was that you take the policies from the state as it related to mental health. And many of our families were not receiving mental health services that could have otherwise received them, simply because of how they were interpreting and applying those state policies, those state regulations. And so once we noted that, and we noted how many of our families were getting declined for services for the same reason, we went and provided a training to that organization. And so no policy had to be changed. We just had to provide the training. And so that enhanced access to services, just based on ensuring that the staff was equipped to understand what the state regulation intention was. But again, we only identified that through tracking it, right? So we took stories and we tracked the experiences of community health workers, identified the barriers, and then either instituted, like I said, trainings, conversations, or address the policy itself.
Thanks, Ruth, for sharing that strategy. Sounds really interesting. And I know that IPHI is thinking that that may be something we want to consider as well. And we have reached the end of our webinar, so I do want to thank everyone for their time. In terms of next steps, Rebecca dropped in the chat a survey that we would like everyone to complete to give us a sense of how valuable or what may be some of the improvements you identified for our webinar series, as well as what do you see as next steps? This work on racism as a public health crisis doesn't stop at the end of our 4-part webinar series. There is still obviously much to do. And so we want to get your insight into what might be next steps to continue this work. So please complete the survey when you have a chance. I also want to thank our panelists for today, Dr. Oliver for his presentation, Ruth Frierson, Shanteny Jackson, and Abby Charles, as well as our moderators, Kim Basquette and Rebecca Epstein, who is behind the scenes. Feel free to stay connected with us at the websites for the organizations that participated in hosting this series. And again, we look forward to continuing to connect with you and dialogue around this important and critical issue in promoting health equity and racial justice in Virginia. Again, thank you for joining us and have a good afternoon.